Hi, dear followers, and welcome back on Newspedia. This time, we decided to face a very thorny matter in the medical field, the administration of ketamine to support emergency and essential surgery when no anesthetist is available. In order to know more and deeply analyze this case, we are with Doctor Sebastian Suarez, Associate Global Health Research Scientist at Massachusetts General Hospital, who carried out research in Luanda, Kenya, about the administration of ketamine to patients. So, good morning, doctor, and thank you for your availability today.
Good morning, and thank you very much for having me today.
Okay, thank you to you. We read a technical and specific issue you published in collaboration with other experts on an intraoperative awareness with ketamine-based anesthesia in areas where it lacks, or in particular where anesthetists are absent, like many countries of Africa and Asia. This is very interesting because the use of ketamine is still much discussed in medical field all around the world. So what do you mean for ESM ketamine?
Okay, yeah, thank you for this question. Let me give you a little bit of
Okay.
context first. So,
Yes.
in the world, there are currently 5 billion people with no timely access to surgery. So that's about two-thirds of the world's population. And 30% of that is due to a lack of anesthesia services, which can range from a lack of anesthesia medications, machines, or lack of anesthetists, as you clearly mentioned. For example, in Kenya, we've learned that there are about 0.44 anesthetists per 100,000 people, and there are some areas, very secluded regions of the country that have closer to 0 anesthetists per 100,000 people. So there's a huge gap that needs to be addressed. So that's how the program ESM ketamine arose, and what it actually means of ESM is every second matters for emergency and essential surgery. This program started in 2013 by Dr. Thomas Burke here in the Division of Global Health and Human Rights. And what ESM ketamine means is that we've created a training for clinicians to provide ketamine in support of surgery when no anesthetist is available only.
Yes.
And specifically ketamine, because this is a drug that enhances the cardiovascular system, preserves respiratory reflexes, so there's no intubation or advanced airway management required. And it's been used for over 60 years, especially in these settings, and by military deployed in the field. So since its inception, we've trained approximately 200 providers in Western Kenya to support surgeries, particularly when no anesthetist is available.
Yes, and so regarding this drug, we suppose that will be criteria that regulate the administration. So which kind of inclusion criteria do you follow to administer ketamine on patients?
Okay, yeah. So the first step that we teach the clinicians is they must try to secure an anesthetist. So we request that all of them call their anesthetist at their facilities if there's one available. But sometimes, sometimes there's no anesthetist. But sometimes, if there is, they may be busy in another surgical case, or they may be far away, or they may be on vacation. So it's difficult, but once we establish that no anesthetist is available, then the ESM ketamine pathway is activated on one of 4 different criteria. So the first one, which I believe is the most important one, is when there's emergency surgery. So, for example, a woman comes in with obstructed labor and needs to have a C-section, but there's no anesthetist to support the surgery. So then the pathway is activated so we can give ketamine to help support the cesarean section. Yes. The second one is when delay would compromise would compromise care. So, for example, let's say a patient comes in with a fracture after having a motor vehicle accident, and it's compromising the blood supply of the limb. So they have approximately 2 hours before irreversible damage starts occurring. So if it'll take more than 2 hours to secure an anesthetist, then we also activate the ketamine pathway in this case. The third indication would be when an anesthetist would previously not have been called. So in many areas or many countries around the world, there are certain conditions or procedures that are not being supported by anesthetists. For example, manual vacuum examinations or dislocation reductions. And these are very painful procedures, but because of the culture and historical lack of anesthesia services, they're usually not done with an anesthetist. So then, in this case, there would also be an indication for ketamine administration. And then the last one is when a patient is offered regular care, but they're unable to financially support this care because they may be head of family, they have 2 employments or no employment, and they have to support their 5 children, so they prefer not to have the surgery. So then we would offer this alternative for them to be able to have care while not suffering from financial loss.
Yes, interesting. And according to your study, who can administer ketamine?
Okay, so I'd like to make a distinction first. Ketamine is a widely available drug in many countries, and it's been available for more than 60 years. There's abundant evidence that it's effective and a safe drug, given its unique properties that I mentioned before, and even some consider it to be one of the safest anesthetics because it doesn't require intubation. And for example, it's administered by general practitioners around the world. In many countries, they're trained to provide ketamine in medical school or nursing school. But our program, why it's different, it's because it's based in a low research setting where where anesthetists or specialists are not available. So we're training 3 different types of clinicians to, let's say, fill this gap. One of them is nurses. The other one are clinical officers, or similar to what we call here in the U.S. physician assistants. And we also train medical officers who are physicians who recently graduated from medical school but that are in that step before starting or pursuing more specialized training. So they're clinicians, so they're trained in healthcare, but they don't require that extensive training that would take years. So how we've designed the program is we've created a checklist, a pocket-sized checklist that clinicians can follow. It's a very easy step-by-step process they can follow, where it has the dosage, the initial dosage, the maintenance dosage, what other medications could be administered in case there's a side effect. So it's very easy for them to follow once they understand how it works.
Okay. You mentioned before the administration of ketamine to traumatic patients. What do you think about the potential use of ketamine as a pre-hospital scenario?
Yeah, so I think it's been used before, and I think it's a very adequate space to use ketamine. So it's been widely used by deployed military. And I know, like, for example, it's been used throughout the entire military chain of evacuation from the point of injury until the point of permanent treatment. So say, for example, in the UK, military are transferred from their deployment over to the UK, and all this time the patient is supported by ketamine. Also, clinicians who join the army, they're giving training to use ketamine for the treatment of pain before definitive treatment. So definitely there's a space there. And it's also very valuable in situations of mass casualties. For example,
Mm-hmm.
people who are trapped under debris or under any type of structure, they can receive ketamine, sedation through ketamine, just for pain control and sedation, and that facilitates the extraction of people from these scenarios.
Mm-hmm.
I also think about how it could be useful in the setting of motor vehicle accidents, which is the main cause of injury around the world. Say, for example, someone suffers from an accident on the road and they have a fracture or a dislocation that's very painful, and then paramedics or whoever is helping a clinician who's helping in the field can actually use ketamine to, say, reduce the fracture, the dislocation, or give sedation to maybe to intubate the patient if it's necessary, and they have the
Mm-hmm.
adequate training to do that. So I think there's a lot of space for ketamine in that area.
Okay. Perfect. And speaking about pre-hospital scenarios, let's talk about rural medicine. So,
Hmm.
what we wish to know is ketamine a drug that can help nurses and paramedics in a country with a dominant role of rural medicine, like Kenya, for example?
Oh yeah, definitely. So
Mm-hmm.
in many low and middle income countries, ketamine is already used by many clinicians when there are no anesthetists available. And we actually believe, or the program is based on the belief that everyone deserves or has the right to a fully trained anesthetist who is capable of supporting and managing any complications that may arise from the anesthesia. Unfortunately, training enough anesthetists will take some time, probably not even in her
Mm-hmm.
lifetime, but in the next generation. And most of those anesthetists will end up working in urban areas. As you mentioned, there are certain countries where there's a more dominant role of rural medicine. So I think that training other clinicians to administer ketamine as an interim solution until there are enough anesthetists to provide those services, uh, it would be a huge help just to increase access to surgeries or procedures that would not have been able to perform otherwise.
Mm-hmm. Okay. Okay. And are you working for the diffusion of the ESMK protocol in the emergency and in the pre-hospital emergency settings?
Yeah, so the ESM ketamine program is particularly important in emergency settings. As I mentioned, the program actually arose or started to support cesarean sections to reduce maternal and infant mortality. So it's been widely, it's mostly so even though it started in these emergency situations, the trained clinicians actually adopted the protocol and expanded its use to include more to use ketamine in more painful procedures such as reduction of fractures or dislocations, which do not necessarily require of an operating theater, but maybe just in the emergency setting. And to your second question, in a pre-hospital emergency setting,
Yes.
even though we talked about a little bit about the like previous knowledge on its use in this setting, and I do believe that there's a role for ketamine in this setting. Our program is still considered a research study, so we're not currently looking to expand it to the
Mm-hmm.
pre-hospital emergency setting. First, we're trying to ensure that the benefit actually outweighs the harm before we scale up to other settings. Because even though it's been widely used, there are no actual, like, let's say, randomized trials or anything like that. But we're trying to build up the evidence to make sure that this is something that should be scaled up. But having said that, I think it's definitely something to think about in the future and
Mm-hmm.
how to increase its support for other settings.
Yeah, thank you for this. And are you satisfied with the results you have obtained this far?
Yeah, so
I
we're
suppose
very
yes.
satisfied with the results. I think part of the success is that we partnered with the county and national ministries of health, and they've supported the program. So we have a lot of support in-country support in Kenya, and we also have a strong relationships with the local stakeholders, local physicians, local champions. Actually, the training is performed by local anesthetists and trainers, and so we're just here to support them. And they've been, I think, part of the success is because they've owned the program, and we've given that space of ownership for them. And I also think it's been possible to our funders, which are the LRAS Research for Health and Humanitarian Crises, or R2HC program, and the Saving Lives at Birth Partners, which are USAID, Government of Norway, the Bill and Melinda Gates Foundation, the Grand Challenges Canada, the UK government, Korean International Corporation, Cooperation Agency. So it's a huge different organizations supporting this, and I think having that backup has been very important for the success and results that we've been able to obtain. And I think now we're in the process of scaling up to other regions in Kenya, including counties that are considered to be in a humanitarian crisis because of refugees coming in from other countries, neighboring countries. And this is what we're trying to move towards, and actually expanding the program to ultimately increase the timely access to surgery to underserved communities, and by doing so, achieving universal health coverage, which is one of the priorities in Kenya right now.
Okay, thank you very much, Doctor, for your brilliant explanation of your interesting study, which is and will continue to be the base of the rescue and the use of ketamine in emergency, and that will help many people, and is helping still right now many people who are in need.
Yeah, no, well, thank you very much for having me. And if you have any additional questions or anything to follow up, I'll be happy to provide that for you.
Okay, I hope to have you soon in line for other interesting topics and updates, if you wish.
Yes, I'd love to.
Okay, thank you very much. Dear followers, this was Dr. Sebastian Suarez from Boston. Keep on following emspedia.com for further issues. Have a nice day.